caring for HIV-positive women today. Okay, so this is special populations. Okay, so I would like just to start by pointing out how special is it when we talk about a population that represents such a large proportion of HIV infections worldwide. 51% of HIV infections worldwide occur in women. So are they really a special population? And we'll see why probably there are some features that currently mean that we do need to regard that women as a special population, in the sense that perhaps we should pay a little bit more attention about some of the issues that relate to the care of HIV-positive women. So women represent a large proportion of infections worldwide. Of course, we are in Eastern Europe here, and in this region, for example, 40% of all HIV infections occur in women. Of course, the situation globally has been improving in recent years. Women have better lives thanks to antiretroviral therapy. But let's not forget that from a global perspective, there is still a large proportion of women, 27%, that, for instance, cannot even access antiviral therapy during pregnancy. So the situation is improving, but is not perfect just as yet. So why do we think that women may actually be considered as a special population at this very moment in time? It's because despite the fact that they do represent 51% of infection globally, they only represent a minority of people that go into clinical trials. As you can see here, under the best circumstances, you get about 35%. But the vast majority of trials do not recruit more than about maybe 15–20% of women. So I understand that there is now sort of an aim, when designing new clinical trials, to try and recruit at least 25% of women within the trial. So that is an improvement in terms of aspirations, but of course, again, we will have women being underrepresented within studies. So what are the factors that may actually impact in terms of gender differences that may have an impact both in disease pathogenesis, treatment outcome, the way we provide care? So there are a number of different factors, of course, that could take a few hours to just discuss all of those. But for instance, there are some biological differences, perhaps in terms of, well, for sure in terms of susceptibility to infection, profile in terms of immunoactivation, we'll discuss that a little bit later, perhaps issues around compartmentalization of infection, pregnancy hormones may all play a role in disease progression and so forth. We will focus on treatment during my presentation, but there are issues around pharmacokinetics, pharmacodynamics, drug toxicity and tolerability, and also we will discuss virological outcomes. I think also when we discuss about the care of HIV-positive women, we should take into account the importance of psychosocial factors into both engagement with care and also we will see outcomes of antiviral therapy. They do bear quite a significant impact in this population. And of course, there are important research needs that need to be addressed around access to care, the support that is required to optimize outcomes, the treatment we deliver overall, and even in the cure agenda, I think there has to be some sort of gender-related consideration that needs to take place. Okay, so pre-ART. Pre-ART, we know that women, both with and without HIV, have a higher CD4 count than men. We also know that before introducing antiviral therapy, once we adjust for the CD4 count, the HIV viral load is in fact lower in women than it is in men. However, what is really puzzling about the natural history of HIV infection is that despite the CD4 count being higher, the viral load being lower, disease progression is not different in women compared to men. We also know from studies that pregnancy does not influence the CD4 count, does not influence progression. And looking at the immunoactivation profile, we know that before starting therapy, women have a more favorable profile. For example, they have lower serum CRP, soluble CD14, and LPS than men. So that is sort of what we know from sort of pathogenesis studies. So what about treatment? So you're familiar, of course, with the START trial, so I will not go into the details of the START trial, but I will try to address the gender sort of related aspects of the START trial. You know that this is a trial that randomized people with CD4 counts above 500 to either receive immediate ART, but keep in mind that immediate here does not mean immediate at the time of diagnosis. Patients had been diagnosed for about a year, a median a year, before they actually were recruited into this trial. So these are people with a stable infection that were randomized to start ART immediately when the study opened, versus the deferred ART group that waited until the CD4 count declined below CD4 count declined below 350, or there was an event, a clinical event. Okay, so there was a composite endpoint that included serious AIDS or death from AIDS and serious non-AIDS related events and deaths. For instance, cardiovascular disease, end-stage renal disease, decompensated liver disease, and cancers, of course. Okay, so recruitment. This is the recruitment, as you can see, from Europe, 33% of participants, but this is a study that recruited worldwide. How many women were in the START trial? 27%. So we are aiming for at least 25%, though this study managed to recruit 27%, which is acceptable. Okay, so this is now looking at the primary endpoint. As you will know, the immediate arm, the arm that started ART immediately did better than the deferred arm, and based on the results of this study, we now recommend starting antiretroviral therapy regardless of CD4 count in people with HIV. But what about the effect of gender? So as you can see, there isn't really any marked difference in terms of males versus females, and the advantage of starting ART immediately, and you understand now what I mean by immediately, the advantage is actually similarly important in men as it is in women. So that is sort of the summary. So a few considerations around the START. So overall, 1.8% of participants in the immediate arm versus 4.1% in the deferred arm experienced the primary endpoint. So risk is small, but nonetheless there was a significant difference between the groups. There was a 57% reduction in risk in people who started ART immediately, which was evident for both AIDS and non-AIDS events. Particularly there was a significant difference in terms of serious AIDS event, TB, and cancer. And interestingly, most of these events occurred at high CD4 counts, so not just in the group that experienced a significant drop in CD4 during the study. There was no obvious impact of gender in the outcomes of the study, and there were not really other gender analysis that were performed within the study, or as far as I know are planned within the study, except for a bone mineral density sub-study, which however it's hard to really make too much of because it only included 3% of women that were post-menopausal, so those are a greater sort of risk of negative consequences of bone demineralization. So this is the START. So has the START answered the question of when to start antiretroviral therapy in women? I think we can say that the inclusion of 27% of women and the fact that the analysis didn't show a difference between men and women is reassuring in the sense that we can certainly say, yes, women, like men, should start antiretroviral therapy close as possible to the time of diagnosis, and certainly regardless of CD4 counts. However, I think we will discuss during the presentation how important it is to ensure that the individual, woman or man, understands what the goal of treatment is and is ready to start before we jump with treatment. Okay, so what about the efficacy of antiretroviral therapy? There have been a lot of studies, most cohort studies, that have analyzed whether the outcomes of antiretroviral therapy are better in women or in men. Don't worry about the sort of the fine aspects of this slide, but as you can see, these lines tend to go both ways. So some studies have found no difference. Sometimes instead studies have found a difference that is in favor of women, and sometimes they found the difference is in favor of men. So obviously the picture is much more complex than sort of we can appreciate. So let's see what data we have. I've just cherry-picked a few. So there is, of course, improvement that is happening. So for example, if you look at women in Germany, in a multi-center analysis that was presented just a few months ago, you can see that the situation has improved between 2008 and 2015 in the sense that the sort of in women, 91% now are on antiviral therapy, antiretroviral therapy, and as you can see also the proportion of with virological suppression has gone up. So that is good news. We've also done a study in the UK. This is called the ASTRA study. And the question that we were asking in this study, we are still asking in this study, is what are the factors that predict the virological suppression in people who start first-line antiretroviral therapy? And looking particularly at the predictors of virological suppression after 6 months of ART, we did an analysis according to gender. We have women, men who have sex with women, and men who have sex with men. So in the UK, in this large cohort, what we found was that several thousands of people were recruited. What we found that overall the best virological outcomes after starting antiretroviral therapy was seen in the MSM population, with women doing less well, but also men who have sex with women, so the heterosexual male population also not doing as well as the men who have sex with men. And as you can see, there is also a significant impact on mental health with people reporting. There was a questionnaire reporting depression doing not as well as those that do not report depression. And this is important to appreciate. This is a factor that affects both genders in the sense that the impact of depression is equal whether you men or women, but of course there are issues around women experiencing the symptoms of depression more commonly in this cohort. So what are the key findings from this study? So as we said, men who have sex with women and women compared with men who have sex with men were more likely to have detectable viral load after starting antiretroviral therapy. I didn't show you the data, but those that suppress, in fact, had also a greater risk of rebounding after starting antiretroviral therapy. The differences, though, in terms of comparing, say, women with men who have sex with men, were basically explained by the socioeconomic circumstances. So if you are a woman, you are more likely to be under difficult socioeconomic circumstances in the United Kingdom than men who have sex with men, and your outcomes are not as good. Interestingly, the impact of unfavorable socioeconomic circumstances were greater for women than it was for men who have sex with men. For men who have sex with women, so for the heterosexual men compared with the MSM. So women suffer more, if you like, from negative socioeconomic circumstances in this particular setting as they impact in terms of virological outcomes of ART. Okay, there's also been an interesting study from the Swiss cohort that follows the same sort of lines. They compared women and men starting antiretroviral therapy in Switzerland. As we said, women before starting ART had a lower viral load and a higher CD4 count. What they found was that women were more likely to switch ART after starting. They were also more likely to stop ART in the first year, and this was not necessarily driven by pregnancy. In fact, there was a lot of stopping regardless of pregnancy issues. Also, what they found was that women had a lower probability of achieving virological suppression in the first 2 years of ART. And again, what we keep finding in Switzerland, like we saw in the UK, in fact, that these differences between men and women were at least in part explained by socioeconomic and socio-demographic factors. Okay, so what about the treatment selection? So we've seen the guidelines. EACS is about to come out. It will be released soon, the new guidance. We've seen the DHHS guidelines. Basically, as you can see, integrase inhibitors now are the recommended regimen. And I think there is good tolerability. There are good reasons to think that this can be good regimens in women as well. But what is the evidence that we have? And will they impact in terms of, will they make a difference in terms of how well women do after starting antiretroviral therapy compared to what we used to use until recently? So we don't know really. So what are the questions? Does gender influence the choice of the initial regimen? Should gender influence the choice? The guidelines don't seem to think so. And do we have a discussion with women about the treatment choice in accordance to the different life stages they go through and the needs which may change during the life of a woman? Do we keep thinking about those things? Okay, what do we need to consider when we select a regimen for treating HIV in women? Of course, we need to think about the adverse effects profile. We need to think about the childbearing potential, desire for likelihood of pregnancy, the safety of antiretrovirals, particularly in the first trimesters, whether we have data or maybe the data are insufficient, choice of contraception, any potential drug-drug interactions, either during childbearing age or maybe later when women may be accessing HRT. Okay, so what we know from the studies, a bit sort of historical data looking at toxicity of antiretroviral therapy in women in sort of when there was still a lot of use of AZT, and I understand that there is still a lot of use of AZT in many regions of Europe, including Eastern Europe. Women tend to experience more grade 4 anemia than men do. But generally speaking, we also see that women are more likely to either change or discontinue antiretroviral therapy due to symptoms such as skin rashes, neurological symptoms, and also constitutional symptoms such as fatigue, for example, headaches, tiredness, but also as a result of poor adherence. Remember what I told you about the fact that before starting therapy, women have a more favorable immunoactivation and inflammation profile than men. Interestingly, once they start antiretroviral therapy, they do not preserve this more favorable profile. There is a study, which I think should have now been published in the Journal of AIDS, that shows that after 48 weeks of antiretroviral therapy, the levels of gamma interferon and TNF-alpha remain higher than they are in men. So maybe the response in terms of immunoactivation and inflammation to ART may be different in women compared to men, and this certainly deserves further studies. Okay, so I'm going to now show you a couple of clinical trials that actually only recruited women. So we are looking now at a sort of change of sort of attitude, and we have 2 clinical trials I can show you that have only targeted women. Now, I want to immediately say that the trials are a little bit short-term, and that, in fact, we would like to have seen a longer follow-up in this particular group. But anyway, this is what we have. So the first study that I want to show you is actually the second that was performed, but I'll start with this one. And it's the ARIA study that was a ViiV trial that compared the single tablet formulation of dolutegravir, abacavir, and lamivudine once daily versus ritonavir, boosted atazanavir with co-formulated tenofovir and FTC. And the primary analysis was done at week 48. So this recruited ART-naive women who were hepatitis B negative and HLA B5701 negative in order to allow for randomization to abacavir. Enrollment, this is where enrollment took place. So it was out of 499 patients, 134 in the USA, and the rest, as you can see, is spread across the different regions of the world. So what was the conclusion? The key conclusion is that the dolutegravir arm did better than the atazanavir arm. This was designed as a non-inferiority trial, but in fact the statistical analysis showed superiority of the dolutegravir arm. So, and this was true across different subgroups. So in terms of viral load, as you can see, responses are 80% for the dolutegravir arm versus 64% for the atazanavir arm in women who started therapy with a pre-ART viral load greater than 100,000. So that is an important observation. In terms of drug emergent resistance, there wasn't really very much happening for patients over the 48 weeks, for patients who experienced virological failure as defined by the protocol. There was no integrase resistance emerging. There was possibly one NRTI mutation emerging on the dolutegravir arm, and there was one M184V emerging in the atazanavir arm, but no PI resistance. So resistance has not been a great sort of problem, a significant problem in this study. In terms of adverse events, remember we always are interested in looking at the adverse events. Overall, the dolutegravir arm was better tolerated than the atazanavir arm. And as you can expect, of course, there was less jaundice and ocular icterus in the group that received dolutegravir. Okay, the conclusion of this study, what are the conclusions? That in treatment-naive women, the dolutegravir arm did better than the atazanavir arm at 48 weeks. You may wonder why the choice of the atazanavir. Would you have chosen atazanavir to compare, the dolutegravir to, and would you have predicted that the atazanavir could have done better than dolutegravir? Probably not. So the cynical will say you choose your comparator well, and then you end up with a great outcome for your drug. But I don't think it's just that simple, because I think that the choice of the comparator arm is also dictated by issues around the safety of drugs in pregnancy and all the other considerations you may need to make when you're designing a study for women. So nonetheless, I think these are good data. And I also think that it's good to see data about the impact of the drug at high viral load, because there is a perception still persistent out there that necessarily the boosted PI will do better in people with high viral load, but we keep seeing that that's not necessarily the case. So that is important to appreciate. Safety profile was similar in women as it has been reported from other studies that included mostly men, so that is an important consideration as well. Okay, the second, which was the first, but it's the second study I'll present, is the Gilead Waves study that randomized women, only women, to receive the co-formulation of tenofovir, FTC, elbaitegravir, and cosibistat, and compare that again to the Truvada boosted atazanavir. So that is the population. And again, what was found was that although the study was designed for a non-inferiority, in reality, the elbaitegravir arm did statistically better than the atazanavir arm. So we can now say that also the co-formulation of elbaitegravir, tenofovir, FTC, and cosibistat does better than boosted atazanavir with Truvada in women. Okay, so again, breakdown in terms of viral load, similar results in the sense that above 100,000 copies, the elbaitegravir arm had a higher levels of virological suppression compared with the atazanavir arm. In terms of resistance, there was one mutation, one patient with a D67N, so one NRTI mutation in the elbaitegravir arm. There were 3 M184 VRI, so lamivudine, emtricitabine resistance in the atazanavir arm. So again, resistance infrequent, not dramatic. Of course, we are also interested in safety again. There were no differences between the two arms in terms of changes from baseline in eGFR. Of course, remember, both groups are receiving Truvada, tenofovir, and both are receiving a booster, cosibistat and ritonavir. Spine and hip bone mineral density changes were also similar in the two arms. The lipid profiles were overall similar, although interestingly, total cholesterol was higher in the elbaitegravir arm compared with the atazanavir arm. But overall, the tolerability of the elbaitegravir arm was greater, and there were fewer discontinuations due to adverse events compared to the atazanavir arm. Okay. The other interesting thing, and I'm coming sort of towards the last part of the presentation, which I will touch on very quickly, is that there was a difference across the world in terms of outcomes, with women recruited in the USA, for example, doing not very well overall compared to outcomes on either arm of the study, compared, for instance, with other regions of the world, such as Uganda, where women did fantastically. And again, this points to differences in how women approach care, retention into care, adherence issues, which reflect the impact of socioeconomic circumstances on, in a certain society on women. And this has been seen in another study, which is the ACTG A5257 study, that also looked at first-line ART with boosted atazanavir or raltegravir or boosted darunavir in combination with Truvada. And what they found was that this is in the USA, this is a study where men did much better than women. However, when they looked at, sort of at the reasons for these differences, it seemed to be related to ethnicity, so that people of black ethnicity and to a lesser extent of Hispanic ethnicity did worse than people of white ethnicity. And again, it's an issue of socioeconomic, psychosocial dimensions and how they impact on women in a certain society and how they reflect in adherence and virological outcomes. So that is the key issues. And if you look at other additional factors that were associated with an increased risk of failure in the study, you will find that there is, of course, adherence, there is low income, less education, history of IV drug use, and so forth. Okay, so in conclusion, what do we need to think about? There are issues, the psychosocial dimensions of sort of treating women must be kept in mind when we approach treatment and we manage also women on the long term. We know that women internalize stigma quite significantly, that leads to depressive symptoms, to a perception of low social support, loneliness, and all of that has a negative impact on adherence. We know that women, when they start, when they get diagnosed with HIV, have a significant impact on their mental health, their reporting of depression, self-blame, feeling of rejection, sense of isolation, anxiety, all really pick up after the HIV diagnosis. So we do need to take into account this particular sort of impact. So overall, a lot of factors need to be taken into account when we approach the way we manage women, how sort of things that influence access, engagement, and treatment outcomes. Very, very complex, what I call the psychosocial dimension is what we need to take into account when we provide the care. So, in conclusion, I hope I've made the case strong enough that we need to approach HIV treatment in women not just by thinking about, okay, are you ready to start antiretroviral therapy and which regimen shall I give you? I've shown you that there are good data supporting the use of currently recommended regimens. However, I think I've also showed you that we do need to think about the multifaceted aspects of care in women. We need to provide psychosocial support as a part of the comprehensive care package. We need interventions that look specifically at the impact that the socioeconomic factors have on the way women engage with care and directly on their virological outcomes. I think we need to do more research that strives for equity of access to care. We need to include the measure of socioeconomic factors when we study outcomes of antiretroviral therapy. And I think also, finally, we need to think about the care of women, not just in terms of reproductive care, around the pregnancy and their children, but also beyond. And certainly we need to start to be prepared for addressing issues relevant to an aging population of women. And I think I'll stop there and remind you that the European AIDS Clinical Society has now created a special interest group that is specifically looking at guidelines and standards of care for HIV-positive women across Europe. Thank you very much.
Thank you. I think it was a very nice overview. We propose to have questions to you directly and before we move to the pediatric population. And let me start with the first question. I think you pointed out that only 27% of all trial population is women, but the clinical guidelines...
Less.
Max 27? So it's a quarter?
27 for start, yeah.
Clinical guidelines are mostly based on clinical trials?
Yes.
So my question is, do you think we do justice to women, or should we have separate guidelines how to treat women? Or is there no major bias and can we actually lump the women into the larger group?
Well, it depends. I think it's always very important when a trial is reported and then incorporated into guidelines. It's always important to see how many women actually were present, because some trials, the proportion is as low as like 10%, 15%, and then you really need to start thinking about it, particularly if you think that some of the safety profiles of a certain combination may actually have a greater impact in women, perhaps in older women. So it's important to look at that table we all skip, which is the baseline characteristics of the trial. Have a look at that, because sometimes you see few women, then you look at the age distribution, then you can think, okay, actually I'm treating a population of women who's getting older. How do I make the decisions about older women, bone safety and renal safety and HRT and all that kind of issues. So I think we do need to look at that. And the guidelines should be a little bit more specific about that aspect.
So you think there is a statistical problem to them, because studies are powered to show superiority or inferiority, but it's always based on the total population. So do we have theoretical risk that we are underpowered specifically for women?
I think there is the risk. In some studies there is actually more than theoretical risk. I think if you were to break down the populations in terms of gender, you will not achieve the power to demonstrate superiority or inferiority in some studies, not all. And I think it's good to hear that now there is sort of a push, at least in some companies, to aim for at least 25% recruitment in women. I think that that's a good way to start.
So maybe I'll ask a question if we don't have any from the floor. So regarding pregnancy, we didn't have time to cover it, but sort of in a nutshell, what's your choice sort of in a resource-rich and a resource-limited setting for pregnant women as far as regimen?
Well, I mean, so in terms of regimen, we use, well, so it's a bit complicated because UK has been always a little bit funny in that point of view. So my own experience reflects that. So we've used a lot of efavirenz in pregnancy. So we don't, we tend to treat women regardless of the pregnancy issue. Efavirenz for many years was our first line, and we wouldn't change if pregnancy occurred on efavirenz. So that has been sort of the stand. Now we don't recommend efavirenz first line anymore, and probably for women, we of course we've seen the data from now the dolutegravir, then the wave. So I think there is reassurance about the choice of first line regimen. So we will use dolutegravir, we will use elbapygravir. But with the pregnancy issue, I think what you have is just that, especially with new drugs, you don't have enough data. So raltegravir, we feel a little bit safer in that sense because it's been around for many years and we have good data about raltegravir and pregnancy. So that is my preferred choice. We don't use a lot of PIs still in women. We use darunavir, but of course we need to dose adjust in the third trimester because the exposure to darunavir goes down in the third trimester. So then women end up on a higher dose of darunavir, on the twice daily dosing, and not everybody likes that very much, as you can imagine. For resource limited settings, I think probably there is still extensive use of Calitra, and I think that there is a very good record with that as well.
Microphone 2, Milos.
I have a question because we have probably the second most difficult to treat population are women with
Yes.
especially with delayed diagnosis who are just recently diagnosed.
Yes.
There's high virological failure rate in this. Is there any trial coming into this population, especially in the context of TAF, which might be very beneficial in this population?
So there's been a lot of discussion about that, and as far as I know, there is no trial that has been designed specifically to actually tackle that issue. But there is interest in trying to get perhaps some investigator-led studies to look specifically at this population, use of HRT, in sense, how proactive we are in asking women about their symptoms. There is a perception out there that women with HIV don't experience as significant perimenopausal and menopausal symptoms as women without HIV do, but it's more likely that their symptoms are different, and that also we are not very good at asking them about it. So number one, let's ask about what the issues are around that, what they are experiencing, give them enough support. In my experience, it's more likely for a woman of that age to end up on an antidepressant than it is likely that she will have a discussion about her, menopausal symptoms and whether, there are ways of addressing it. So there is an enormous work that can be done just around that in routine clinical practice. I don't know that there will be clinical trials just for that population. But the bone health issue is a concern, I think, and certainly this is my own preference, personal. I will say that, the TAF seems to be a safer option than the TDF in an aging population, particularly if there is already evidence of osteopenia.
Wonderful. So we need to move on. Thank you very much.
Thank you.